Welcome everybody to week 4 of the Leadership Alliance Virtual Professional Development Series. This week, our webinar is entitled Pathways to Health Equity and will be moderated by Dr. Damani Piggott. Dr. Piggott is an associate professor in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine, with a joint appointment in the Department of Epidemiology at the Johns Hopkins University School of Public Health. Dr. Piggott graduated from Morehouse College with a degree in biology and Spanish. He subsequently obtained his PhD degree in immunology and his medical degree from Yale University. He completed clinical residency training in internal medicine and pediatrics at Yale New Haven Hospital and fellowship training in infectious diseases and epidemiology at Johns Hopkins. Dr. Piggott has worked on clinical and research projects in urban and rural communities in the United States, the Caribbean, West Africa, and South Africa. He is actively engaged in the clinical program centers on understanding the biological, behavioral, and social pathways necessary to improve survival and quality of life for persons aging with HIV, with particular focus on those most severely affected by those conditions, namely the socially marginalized, historically vulnerable, and resource-constrained communities. Dr. Piggott has served as co-director for the Centers for Disease Control and Prevention-sponsored James A. Ferguson Emerging Infectious Diseases Fellowship Program and has served as assistant dean for graduate biomedical education and graduate student diversity at the Johns Hopkins University School of Medicine. Dr. Piggott is the inaugural Associate Vice Provost for Graduate Diversity and Partnerships and director of the Vivian Thomas Scholars Initiative at Johns Hopkins. He is a founding member of the Inclusion, Diversity, Access, and Equity Task Force of the Infectious Diseases Society of America. And he is a Leadership Alliance doctoral scholar. On behalf of the Executive Office and the Leadership Alliance Consortium, it is my distinct pleasure and privilege to welcome Dr. Damani Piggott as the moderator for this so important webinar. Thank you.
Thank you so much, Dr. Astorini. It's such a pleasure to be able to join for today's session. And we're all so grateful for just the phenomenal work that you, Dr. Astorini, the Leadership Alliance Executive Office, and everyone at Leadership Alliance is doing every single day to lift up our space in just so many exceptional ways. So today's discussion, entitled Pathways to Health Equity, could not come at a more critical juncture in the arc of our history. The National Academies of Sciences, Engineering, and Medicine defines health equity as the state in which everyone has the opportunity to attain full health potential, and no one is disadvantaged from achieving this potential because of social position or any other socially defined circumstance. What we have continued to bear witness to in such stark relief through the recent lens of the COVID-19 pandemic and across multiple other recent disparate currents in our national and global space is that the opportunity to achieve full health potential in many ways has long not been afforded to all in our society as it should be. I'm just so grateful to be joined today by 3 exceptional panelists, Dr. Galarraga, Dr. Kontos, and Dr. Arredondo, all of whom have been tremendously committed in both thought and action to how do we tangibly move to realizing the vision of a more equitable society. Just a brief note on how this session will run. Each of our panelists, Dr. Galarraga, Dr. Kontos, and Dr. Arredondo, will share a bit about themselves and share some initial reflections on this topic. We'll then move into a discussion section with all of you. Please use the Q&A function to post questions. and we look forward to a lively discussion. With that, I'd like to ask Dr. Galarraga if you could start us off.
Thank you so much for the invitation. Again, it's a pleasure to be back at the Leadership Alliance. I've participated for a number of years. This is one of my favorite things to do in the summer. Only better than this is swimming out in the bay, in the beautiful Narragansett Bay, where I like to spend some time as a long distance swimmer. I've done 12 years of Save the Bay, which is 2 miles in open waters from Newport to Jamestown. So that's the only thing that is better than this. Why do I like Leadership Alliance so much? Because it's a great program. It's a great program that helps people to move hopefully into research careers. I remember when I was starting, a very similar program, Institute for Recruitment of Teachers at Andover Academy, helped me, give me that extra push, that extra nudge to be able to apply for the PhD and do research. And so I'm now associate professor at Brown University School of Public Health. I'm also the director of the HSR PhD program there. So if you're interested in health services research methods and you're ready for thinking about a PhD, keep us in mind. We are a very, very competitive program. Sorry about the shameless plug. And so again, my training is in health economics. That's something I wanted to do from the very beginning, since high school, to be honest. I am an immigrant. I was born and raised in Ecuador, and I came to this country over 32 years ago to study. I wanted to study. That was my dream. And I was very lucky to be able to enroll at a public university, at the University of DC. I was, very poor immigrant. I had to work in the morning and nights, and to study at nights, work in the morning, study at nights. And I was able to get through undergrad, and then I did a master's, worked for a while, and then I was able to get into a PhD eventually. But I always kept in mind, why is it that we have a lot of poverty issues? I grew up in a poor country, and also as an immigrant, I saw a lot of poverty even in the US. And so I was interested in the marginalized population. So a lot of my work, after I worked for the UN in Ethiopia in the late 90s, and I saw HIV, because a lot of young people were dying very young, I realized, well, this is a very important issue. So I've been working on HIV for the past 22 years. And after I finished my PhD, I went to Mexico. And in Mexico, the epidemic, the HIV epidemic, is concentrated in men who have sex with men, and particularly a subgroup of them who are male sex workers. And even during the pandemic, of course, even during COVID-19, these marginalized populations have to keep working. Of course, they have to feed themselves. They have to put a roof over their head. And even though it was even more dangerous, they have to keep working. So here you have some recent news from Reuters, from El País, from AP, and if you type any of these keywords, you will get dozens, perhaps even hundreds of articles of all the tough things that marginalized populations needed to do, including sex work in Mexico. And why do we concentrate on these populations in Mexico and in other countries? Of course, because they are very marginalized and very vulnerable. If we see the next slide, please. This is some of the work that we have done. We have documented that among male sex workers in Mexico City, the incidence of HIV is 5.2 cases per 100-person years. So if we follow 100 male sex workers for a year, and they are all HIV negative, say on January 1st, on December 31st, on average, 5.2 will be HIV positive, will have zero converted. That is very high. That's some of the highest HIV incidence rates that you can see anywhere around the world. And so it's very important that we concentrate on these marginalized, vulnerable populations. And this is, of course, just one example. There are very many vulnerable, marginalized populations. And so it's very important that we do our best as public health researchers to try to improve those conditions. So one of the things that we can do is now we don't have a vaccine. One of you already asked, why is there not an HIV vaccine? We don't have a vaccine, but the closest we have to is something called PrEP, pre-exposure prophylaxis, which is a pill that we can take once a day, and this prevents the virus to come in. And so it is indicated for persons at very high risk of infection, including serodiscordant couples. So if my my sex partner is known to be HIV positive, then I'm in a serodiscordant relationship and I would have to take PrEP every day. Or for male sex workers, for example, or people with multiple partners. And so it's very important to continue doing this research and to do implementation science around this. And so, for example, in the next slide, we can see some of the work that we've done with male sex workers in Mexico City, where we have incentivized the male sex workers to take these pills, this pre-exposure prophylaxis, 1 pill a day, to reduce the risk of HIV infection. So this is recent work, and a lot of my work is economic-based intervention. So incentives for behavior change, or insurance, or microfinance, or other types of incentives, be it positive or negative, right? Positive to, in this case, incentivize PrEP use, and sometimes negative to reduce the use of some things that may be harmful. And so, as it may not be new, perhaps, male sex workers would prefer to receive higher incentives. You can see on the top left, the $45 are preferred than 30, are more preferred than 30 or 15. They also would like, in the top right, you can see that they would prefer fixed incentives versus a lottery incentive. Obviously, it's a time of a lot of uncertainty, so they don't want to have the unknown of whether they'll receive the incentive or no. They prefer to have it fixed. And in the left bottom, you can see that they don't have a whole lot of difference between it being an electronic gift card versus a voucher. Voucher, you can go to the supermarket and buy something, an electronic gift card, they can use it. There's no difference there. You can see the 95 confidence intervals overlap. And how do we know that they are being adherent? They're taking their pill every day. We've done hair samples. So the antiretroviral, if I take it every day, it accumulates in my hair. So you take a few strands of hair, you can analyze it, and you can see that the antiretroviral is there. So we've done that, and of course they prefer hair over blood samples, even though they are very used to doing blood samples. So this is just a small sample of some of the work we've done with a marginalized population in Mexico, and I'll be happy to talk more, and looking forward to the panel. Thank you again, and very nice to be here.
Thanks so much, Dr. Galarraga, for that. Dr. Kontos?
Hi, thank you so much for having me. I will offer a little bit of a different perspective since I currently sit within industry. So I am the managing editor for several specialty areas within a clinical decision tool called Dynamed, which is offered. Our parent company is EBSCO. Many of you might be familiar with EBSCO as researchers. We use it as we offer lots of aggregate researching tools, but they also own proprietary content, including the product Dynamed, which is one of several products within our clinical decisions suite. Next slide, please. So I'm not going to go over this very busy slide, but this was just kind of as I was thinking about my career pathway and all the different roles that I've had with my research degree. So I'm actually an alum of Brown. I graduated with a degree in biomedical ethics. It was actually a couple of years before the School of Public Health was created at Brown. And then from Brown, I really got an interest in direct public health service and worked both at the Rhode Island Department of Health and then later at the Massachusetts Department of Health. And that's where working within communities of need, specifically among my focus area was cancer prevention, I realized, I really wanted to focus on health communication and went to the Harvard School of Public Health, and I got my master's focusing on health literacy, then returned to the Massachusetts Department of Public Health to put that degree to use. And again, working in cancer prevention communication within communities, and then really wanted to have more of an impact and thought going back to school for my doctorate would let me work on issues in a larger scale within the public health arena. So I went back to the Harvard School of Public Health and I got my doctoral degree in social epidemiology, where I focused on cancer prevention, working within all of my research actually all of my research has been community-based research. I had a postdoc through NCI, and then, did the typical academic track and had a faculty position at Harvard Medical School and Harvard School of Public Health, working at the various hospitals, both Dana-Farber, Brigham, and Beth Israel, and focus on health disparities research. I was a primary principal investigator and co-investigator on several R01s, P50s, you kind of name the institute. I was doing that. And then what I wanted to highlight here is that every point on this path has been, my career path has been influenced by something in my personal life. I think that might happen to a lot of us, especially me as a woman. And then I became a wife and a mother, and all of the kind of outside influences that impacted my life really steered my career path. And I made the difficult choice to leave academia about 6 years ago, after having gone through several personal challenges within my family. I wanted to have more flexibility than kind of academia that was focused on grant funding would allow me. So I left Harvard and I came to EBSCO, and I have been there ever since. So the past 6 years, I've been this managing editor, as I said, and I work on my specialty areas. They add by the day, but it's palliative care, neurology, psychiatry, ENT, and ophthalmology are the areas that I focused on. And then ever since 2020, I've been given additional responsibilities as heading up a lot of DEI efforts, drawing on my training and experiences prior to coming to EBSCO. Next slide, please. So what's Dynamed? Dynamed is a support tool for clinicians at the point of care. And everyone from clinicians at the point of care, but also pharmaceuticals and researchers use our product. And we summarize the most relevant research so clinicians can receive it at the point of care with a short time to answer. I like to say that we're kind of the cliff notes of research. Clinicians are very busy people, and when they're in the office with a patient and they want to see what is the latest guidance on something, we offer that. Our tool offers that. Next slide, please. So how do I use my degree in research within industry? Actually, almost all of our medical editors, writers, and managing editors have degree either in the biological sciences or public health. We almost all have PhDs, and we use that research foundation to apply our evidence-based methodology. So as you can see here, there's 7 steps that we take to critically appraise research. I like it, as a research student and then an investigator myself, I get to be the reviewer. I get to be reviewer 1 and critique some of the flaws. What might be, what weight should we apply to this evidence, and how strongly should a clinician be thinking about this, given the patient they have in front of them? Thinking about internal validity, external validity of evidence, and what does the body of evidence say? Next slide, please. And so, as I said, I'm sorry that this is blurry. I did a screenshot, but within the past 2 years, I've really been able to apply my focus on health disparities and social epidemiology to my work at Dynamed by offering an additional lens. We are focused now. We have a specific focus to add health disparities and health equity content throughout our products. I helped author an inclusive style guide. So the way in which we write is inclusive of all patient populations. And here's just a sampling of some of the recent work that we've done. So we have a topic dedicated racial and ethnic disparities in obstetric and gynecological care. This is just a little excerpt of it, but it will go on and it presents all the evidence. Over on the left, you can see we have a suite of topics going over transgender healthcare, both for the adolescent as well as the adult patient. And then next slide, please. And then besides the actual evidence that we summarize and put into what we call topics, which is what you kind of saw on the previous slide, we also have different outlets in which to reach physicians and other people within the healthcare industry. And one of those is our blog, which we disperse both on our product, through social media and other outlets. And here's a sampling of some of the blog posts that I have, some of which that I've helped with, and some which other writers in our team have done. So we've really, well, Dynamed is one product within our clinical decisions suite. We have a shared decision-making tool called Dynamed Decisions. We have a nursing tool called Dynamic Health. And through the shared decision-making tool, we've really been thinking about the concept of race norming and what that means. And so you'll see the article on the left was, will estimating GFR without adjusting for race help reduce racial bias in chronic kidney disease? And we explore the evidence on that. Then this was published in 2021, the next one, but it could be published again today. We offer, again, we are an evidence-based scientific product. All we do is present the evidence that has been collected. We don't come with any other lens besides the actual evidence. And here we present the science behind gender affirming care for transgender youth and what the evidence says supporting affirming care for youth. And then the last one is about, again, racial ethnic disparities and maternal mortality and morbidity. So those are the different ways I've been able to use my research degree within industry and also bring that lens of health equity to the work that I do. And I have to say it has been, one of the benefits of working with industry, as I said, I've worked in, the public sector, academia, industry, is the speed at which we can reach the end user. So the end user being the physician, we summarize the research and within less than a month, our product is live and delivered to the physician. And, that's a very different pace than academic research where I was. It often takes a lot longer to go through the whole publication, research, publication process. So that's one of the things I've really liked about my job is the immediacy of the work and the impact that we can have with clinicians. So I look forward to your questions later.
Thanks so much, Dr. Kontos. Fantastic. And so next, I'm going to ask, and I just want to remind folks to please put questions in the Q&A at the tab at the bottom of the screen of the Zoom session. And so next, I'd like to ask Dr. Arredondo, if you can share with us.
Hello, I'm Elva Arredondo, and I'm in the Department of Psychology at San Diego State University. And I'm very grateful for this opportunity and honored to be part of this panel. I've really been inspired by the stories I've been hearing, both personally and professionally. So I'm very grateful for that. So I'm going to start off by telling you a little bit about me and my training, and then I'll shift gears a little bit and talk a little bit about my work. So I'm originally from Mexico, specifically from Mérida, Yucatan, and I came to the US with my mom and my siblings when I was 13, not the age you want to be changing countries. And then I was fortunate enough to be admitted to the University of Washington. And during my training there, or my education there, I benefited tremendously from the Alliance. So I was able to meet other faculty and other role models that looked like me and had career paths that were very rewarding. So I did attain my psychology degree as an undergrad. And then I wanted to take a couple of years off between undergrad and graduate school, mostly to gain more experience in research, because I knew that that was the path I was going to go. Next slide, please. So I worked in Seattle at the Fred Hutchinson Cancer Research Center on a study that promoted breast cancer screening among Black women. And a lot of what drew me to the work was really more of a social justice agenda. I was really appalled that Black women are 40% higher to die from breast cancer than other women, and it wasn't all genetically explained. So clearly prevention and access to care is important. So I knew that I started to hone in on the kind of path that I wanted to pursue. And that's to think about developing programs that can help prevent cancer and other chronic diseases. So I also was becoming really aware of the disparities in different ethnic groups, including recent immigrants. So I really wanted to focus my work on primarily recent immigrants. And the case that I've been doing, most of the work has been in Latinos. So I applied to graduate school. Next slide, please. And I really wanted to pursue clinical psychology because I wanted to develop programs and interventions to address disparities. And I felt like a clinical program could give me that, as in other programs could, but I was really drawn to clinical psychology. And during my training there, I did do community-based programs that help prevent cervical cancer screening among Latinos in North Carolina. And we were working with primarily rural community. And I realized that my training was very individual focused, and I really needed to broaden my training to include more environmental focused interventions. So I pursued a postdoc in the School of Public Health at San Diego State University because I wanted to do community-based work, but targeting the outer rings of the social ecological framework. Because we knew that, certainly motivating somebody to get screened or to, to eat healthy or engage in physical activity was only going to go so far. We really needed to have access to preventive care and safe parks and access to healthy foods in neighborhoods. So I felt like that was an important step in training for me to really do. So given the opportunities that I had then, I started to focus my work on promoting physical activity, given that obesity is high among underserved communities. So it felt like promoting physical activity was a way in which you can help prevent obesity or reduce its risk. Next slide. So I was excited. I found my path. I wanted to develop interventions to prevent chronic diseases. And my approach was, okay, well, pilot test the program in one organization, examine the feasibility and preliminary impact. And if it works, scale it up so that you start to test it in an efficacy trial or an effectiveness trial. So that's what I started to do as a postdoc, transition into assistant professor and later as an associate professor. As I mentioned to you, my approach is doing multi-level interventions to address chronic diseases. And so after 13 or 14 years in this work, I felt really frustrated because we were developing these programs that worked, or we had access to these programs that worked, but they weren't translating into practice. And so I sort of hit this mid-career crisis where like, oh my gosh, I feel like my work is being published, but it's not really being used by the people that I cared the most and I wanted to benefit. So I took a pause and got some training in dissemination and implementation science, which is the science around translating evidence-based programs into practice. And I sort of got rejuvenated and I felt, okay, this is going to be my next horizon. I feel like, okay, if we can figure out how to translate these programs into practice, I'm going to feel like I'm doing meaningful work. Next slide, please. Thank you. So this program that we developed called Faith in Action, and we're working with churches because churches have access to diverse communities, and many of these communities don't necessarily have access to healthcare. So I felt like we were really targeting the communities that were the least or the most marginalized. And we developed a program that was adapted to the church. So we incorporated a lot of scripture. We worked with community health workers, which is in Latino communities called promotores. And we train them to implement these programs, and promotores are really an effective way to work with many diverse communities because they are from the community. You're increasing the capacity to implement the program, and they have the trust of the community. So oftentimes when programs end, these programs can be sustained by the community health workers. So we developed this program called Faith in Action, where we were working with churches and promoting physical activity and working with community health workers. And then we were able to see changes in physical activity and also BMI after 12 months. So we were really happy. But now the new question for us is, well, once the grant ends, how do we sustain this program in the church? Next slide, please. Oh, you can skip this one because this is more the impact that we've made. And a lot of what we're sort of grappling is like, sure, we have a lot of evidence-based strategies. And so how do we really make this into practice? So right now, next slide, please. We're working closely with faith-based organizations to really help us figure out ways in which we can translate this program into practice. So we're engaging church leaders, we're engaging other organizations to really help us troubleshoot ways for us to sustain this program. We know that churches can't finance these programs because most of the churches that we're working with rely heavily on donors. And then physical activity is not priority for the church. So it's clearly not going to be a program that they themselves going to sustain. So how can we bring the key stakeholders who can help sustain this program in these organizations? And we have been working closely with hospitals and YMCAs that are very invested in really promoting this work in churches. So we're just starting this work, and we have 4 more years ahead of us to try to figure it out. So that's sort of the next frontier for me at this point. So with that, I think that's the last slide, possibly, right? Yes. So with that, I'm looking forward to answering any questions you may have when it's appropriate. Thank you.
Fantastic, Dr. Arredondo. Great. So we've made a couple of journeys. We've gone from infection and HIV to chronic disease and cancer. We've gone across boundaries and across countries to Mexico as well. We've gone across faith and food, and we've made quite a journey across our folks here. So it's fantastic to hear this diversity of work in this really important space. So I'm going to start with a question. So really, as you reflect on your work and the spaces in which you work and the focus of your work, how do you think that this comes in a question that has come from our folks? How has the COVID-19 pandemic affected your work in terms of thinking at the intersection of health equity? Any reflections on that? So if I might say, so how has the COVID-19 pandemic affected health equity in the intersection of the spaces and places that you all have been in?
I can offer, coming from, I was in public health for over 15 years, moving into primarily medical space. And when I first came over, crossed over, it was really different. I was doing a lot of similar work that was presented, and I actually just saw Dr. Karen Emmons was one of my mentors. She was on my committee. And so we say that it's horrible to say with over 1 million dead within the United States that COVID-19 was a silver lining, but within the medical community, I don't come as a MD, I come as a social epidemiologist. There was a very much heightened and acute attention to social determinants of health. A lot of physicians who did not previously think about it were thinking about it and had to think about it. And there was a demand from our customer base that we include health equity content, that we think about it. So even our COVID-19 topics that we were building out within product, we had to, it could no longer be ignored. Really. So that's really how it impacted. And most of the work that now I get to do within product is because of COVID-19.
Yeah, if I can jump in to build on that, I think it clearly shone a light, right, on disparities even more. It became much more evident and sort of brought this to the forefront. And for the work that I do in terms of chronic diseases, and the work in the communities that I work with, you saw a vast number of, especially Latino communities, just being impacted. And, largely because of, the fact that you have a chronic disease, you're higher risk for overweight, you see the impact being magnified. But also, in terms of access to care, right? In terms of misinformation, in terms of just on so many dimensions, you sort of saw, okay, we really need to do a better job in helping prevent or helping minimize the burden on COVID on these communities. So so it's infectious diseases and chronic diseases, right? Sort of at a connection point.
I think at the global level, we have to remember more, and perhaps painfully so now with COVID, that we are really interconnected. Many of us in public health knew this from a long time ago, thinking about HIV and other diseases. And I was in Mexico when we had H1N1 in 2009. And so we, did have to basically stay in place for 1 week. I remember when the airports got stopped. And again, as a health economist, I thought that was amazing. And as a public health researcher, I said, well, they're doing exactly what they need to be doing. You just have to, stay in place, and you have to nip it in the bud. Unfortunately, as we now know, that was not done in time in many parts of the world, and we have now the consequences. But again, it's still, even though we see the consequences, I don't see a lot of the change that needs to be done, right? So COVAX is still not funded fully. And when one person is vulnerable around the world, we are all vulnerable. And that we as public health people need to work more on that, and just to increase solidarity, and just to make sure that the vaccines are available everywhere. Because those who are not vaccinated or are not fully vaccinated, that's where you start developing more of the variants, and those circulate very quickly. And so I think once we have vulnerability for some people in some parts around the world, we all are vulnerable. And I think that message needs to be drilled, and we need to think more about how to do more in terms of solidarity around the world.
Thanks for that. Thanks everyone. Thanks, Dr. Galarraga, for, it's definitely something I think we've all reflected on in terms of we're all in this together, but the impact is not always the same on everyone, but we are at the end of the day, right? That's really what one thing that hopefully has come from the pandemic and needs to continue to propagate. So a question about impact. So as you think about your work, right, and connecting, I think there's some themes in the questions we received about how one connects the research with policy, how one connects with community, how one gets messages out, how one activates and creates awareness. So I see in particular questions coming in like, how has social media actually changed the way in which one might communicate one's research, and what were the ethical considerations around presenting research in that way on the social media platforms as well. And I think there's another question, and I know Dr. Arredondo, which says, have you discovered strategies to help promote awareness of your research or access to your research to help promote health equity? So the general theme of communication and having impact through communication, what the modalities there are, how does social media impact that is one question I think several folks have.
Yes, I can offer something first. I mean, I see our product as one channel of that communication. So we aggregate the information, you know, we have systematic literature search. So every day we're looking at the top, not only the top journals like JAMA and New England Journal, but then also specialty journals, which we've added dedicated disparity journals to, and synthesizing that research and providing it, you know, sometimes within days of it being published to a physician. So in that way, our product is one conduit of communication. And then we actually do take really practice changing research, and we help promote it on our social media platforms. So you don't actually have to be a user, you'd have to follow EBSCO or Dynamed or something like that. But I think we are actually one link in that communication.
And I can jump in.
Yep,
I was follow Kontos, so sorry.
Thanks, Dr. Kontos.
Mine was a little bit different in terms of social media, because I see that as a little bit different from the work that I'm doing. But a lot of the answers come from the community. I mean, all of the answers really come from the community in terms of how to best make the programs accessible. So as an example, is that when we tested this program, that we found it to work in the churches. So we were able to see significant increases of physical activity 12 months after baseline. And we interviewed participants and we interviewed church leaders. And what we discovered is that we really should be engaging the church leaders in these programs in a way so that they are role modeling healthy eating and healthy physical activity and promoting the program, and not from the university. It really needs to come from the organization. And we also learned that messages that are very tailored and adapted to the culture within which you're working with. So each church has a very different culture. That's going to make a bigger impact in terms of implementing the program and adopting the program within those churches. So there are a lot of ways in which we can really help diffuse a program and make it really part of weave it into part of the community. And really those answers are going to come from the community in itself. We work very closely with the community advisory board, who are folks from the different organizations that we work with, who can really give us input on how to work with the organizations themselves, but also can give us input on the programs themselves. So, I mean, our partner, we work, shoulder to shoulder next to the community partners. And without their really buy-in and involvement, we go nowhere.
Thanks for that, Dr. Arredondo. Dr. Galarraga?
I used to be afraid of talking to the media. I'm trying to lose my fears because I see how important it is. I struggled and I continue to struggle with the new technologies, even with tweeting. I do tweet, but I just tweet about my papers. Because I see that it's important that we have to, contribute and have a voice, because otherwise those with, bigger loudspeakers overwhelms us, and they may not necessarily have, better answers or more well thought out answers. But so I think we need to engage as researchers at some level, at whatever level we are comfortable. I think with younger generations, we need to engage even more. Obviously, people, engage more with Twitter, with TikTok, and if somehow you can link that to research, that is great. I think that's very important. The only thing I would say also for students, current students, is to try to get out of the bubble, because sometimes we don't understand why people do certain things. So I've worked in Ecuador, in Mexico, and other places with, for example, with insurance issues and looking at the inequities with the indigenous communities. And so why is it that they don't go to, for example, give birth at a hospital? So there's a culture with indigenous culture that is very reluctant to engage with Western medicine. And there are centuries of history of why this may be. And so if we are ignorant of that, we are just, not understanding, and we are just saying, oh, pejorative term, why are you not going to the hospital? And we are ignorant of a lot of history, a lot of baggage. And why is it that, they don't treat me right if I go to the hospital? They don't look at me. They insult me. They don't understand. They don't speak my language. And so we need to understand why people do what they do. And if we are just in our bubble, it's very difficult to do that. So I completely agree with Elva that we need to ask people, why is it that certain things, and have our research be informed and sometimes guided by that.
Yeah, thanks for that. And so in linkage to that, maybe in extension, there's some questions that are thinking about the impact of policies and legislation and how policies and legislation impact health and the health field more broadly, and health issues and health equity. And some of us, is there, one question has been whether there's an ethical duty potentially for some engagement of folks in this space to connect to those policy-making entities per se, appreciably in the context of recent things that are happening in our national space and global space. The question is, again, so there's the awareness to communities and folks who may be directly recipients, and then there's a question of structures and what's the role in that space, and how have we advanced in making efforts to make those connections and affecting the legislative piece to positively impact the health equity piece, and what are the growth opportunities in that space?
I think that again, we need to engage if we have the means or if we have the training. I think for many of us as researchers, we're not trained in communicating, we're not trained in advocacy, we're not trained in lobbying, and but maybe we can still make presentations, right? So engage politically when it's appropriate. And certainly if you're asked, do go to give testimony in front of legislatures or in front of any other elected body, and definitely be engaged in the political process if that's appropriate. That's a topic that you are familiar with, and then endorse the candidate that is doing the right thing for your public health issue. I think we have to engage. If we just are in our cocoon as researchers, we are going to be overwhelmed with those, again, with the loudspeakers that are not doing the research, and then may lead us astray. and not working in the interest of the people, not working in the interest of women, not working in the interest of men, not working in the children, not working in the interest of minorities or indigenous populations, of migrants. And so I think that we need to somehow give voice to these people that cannot sometimes speak for themselves for various reasons. And we have the tools and we have the results of, well thought out research. And so if we just published and do nothing else, I think we're missing an opportunity.
Great. Okay. So I want to move into, there's some questions here that speak to journeys and paths. And I know you all shared your journeys and paths. And as we have the opportunity to connect with folks here for this session who are in the pathway and thinking about what their future journeys and paths are. So one sort of broad question is, how can we as undergraduate students or students in general support and tangibly expand equity in healthcare? And maybe I will juxtapose that question as I appreciate we're approaching the hour. How does one decide which career path, in juxtaposition to that question, how does one decide which career path will be right for them, whether it be academia, clinical, industry, or otherwise? And you all have taken multiple different journeys. And if I could throw in one more, so you can choose which of these questions you wanna do or combine them. What advice would you give to your younger selves? Who wants to go first? I'm happy to repeat them as well. So how can our students here support and expand equity in healthcare and as it stands right now? How should they go about deciding on career paths and the different potential spaces, academia, clinical industry, and otherwise? And what advice would you give to your younger selves?
I can mention career path. I mean, I think my own as an example, you don't have to be limited. Our careers are very long, hopefully. And, if a fork in the road presents itself, I think you can think of it as an opportunity because also as we grow in age, my younger self would not have been able to forecast that my husband was going to get cancer or other things. I could never have seen certain life situations coming down the road. And then when they do, it's okay to change. And I don't regret any part of my pathway. It's all led me to where I am today. And I don't, will I stay in industry? I don't know. I probably have decades more of work ahead of me. And I guess don't limit yourself would be advice. And, I think my younger self would need to hear that. I was very much a student that, wanted to go after a certain target and be very inflexible about that. But, things change.
Arredondo.
I can give a couple of things. So I probably, what advice I would give myself when I was in my 20s, probably take on more professional opportunities or professional development skills. I think that I went into science and I just kind of hunkered down and I was doing my work and I sort of like Dr. Galarraga was saying is that, and I'll probably mutilize your name, I'm sorry. I was really shy and I sort of feel like coming out and being able to be able to tweet and be on social media and be able to give more presentations. I think that probably, those are the stages that I think you're able to really make an impact on the work. And I don't have trouble with working with communities, but I probably could have used more support early on in terms of how to sell yourself, how to sell your work, how to, and I think we're trained, or many of us are trained to be humble and don't, if you're sort of boasting about the work, it's sort of not a good thing. And so I think being able to figure out a way to talk about your work in a way that can make an impact would be important to do early on. I didn't learn that until later. Well, I don't know if I'm still learning it.
Great. Sound advice. Dr. Galarraga, you want to close us off?
Sure. First of all, in terms of what to do now for anybody, again, I think is just be engaged. I think right now it's just a matter of being engaged in a positive way at whatever level you can. And so for whatever issue you think is important, make sure that you're out there supporting the right candidates, making sure that people vote for the people that are, again, pro public health and, pro the causes that you are interested in. In terms of career paths, for me, I think, again, being in Ethiopia, living in Ethiopia for a couple of years was that moment that was a pivotal moment for me when I saw the ravages of HIV. And I just said, this is a very important issue. And I just said, this is like the issue for us, because it was, for me, an issue of economics. And you had antiretroviral treatment in Europe and the United States, but it was, $10, $15, $20,000 per person per year. And you had, I remember, looking at the budget of Ethiopia, and it was like $1 per person per year for prevention and treatment. And like, what can you buy with that? Maybe a pack of condoms at most. And so that's not going to save you once you have HIV. So it was an economics issue, but it was a health equity issue. And that really is what, put fire in my belly. And I said, I need more methods. I really need to go back. I had my master's already, but I said, I need more methods and I need to do better analysis. And the advice I would give to myself back then from, 20 years ago is, again, be more engaged. At that time, I remember just hearing about what was happening, for example, in South Africa with the treatment action campaign. So it's, people being out in the streets protesting and just making a bit ruckus because it's just immoral, unjust, unethical. And when you feel that way, you just have to make sure that you find others that feel like you and just go out and be a social activist, in addition to being a researcher, So we can do positive things with research, but sometimes that's not enough.
So I think everyone has their charge. We're going to close out with that. Clearly, be engaged, be active. I hope you're inspired. I'm inspired by this wonderful, tremendous panel. I know that we've gone over, and I want to thank again the Leadership Alliance for having us as well for this session. And I want to hand it back over to Dr. Astorini.
Thank you so much. Thank you for this powerful panel of discussion, sharing your research, your personal and professional stories and experiences. I feel confident that you have illuminated multiple pathways for our students to think about ways to create access and hopefully obtain health equity. And your advice is just invaluable. So thank you all so much. And for our students, for our audience, please be sure that you attend next week's virtual professional development series, as we will be addressing applying to graduate school and taking that very important next step. So I look forward to seeing all of you. On behalf of the Executive Office of the Leadership Alliance and the Consortium, I want to thank all of you for being so open, and we really enjoyed it. Thank you. Have a great, great week.